Good to go.
Good morning, friends, and thank you for joining on our today's special session on liver health. As you all know, that healthcare is one of the key focus area of CIF, and we have been running the series of events in the past for promoting healthcare, especially on our biennial healthcare forums, to get health experts from Canada and India on single platform to share their expertise, experiences, and best practices. And today's topic is very relevant as it is an issue of concern for a larger number of Canadians as well as Indo-Canadians. Friends, liver performs many essential functions to keep our body healthy, such as helping turn fats into energy, helps in creating blood protein to carry hormones, drugs, and fatty acids throughout the human body, processing bilirubin, removing waste products, controlling immune responses, maintaining glucose, etc. And liver disease actually accounts for approximately 2 million deaths worldwide per annum, and 1 million due to complication of the cirrhosis, and 1 million close to due to viral hepatitis and hepatocellular carcinoma. Cirrhosis is currently the 11th most common cause of death globally, and the liver cancer is the 16th leading cause of death. Combined, they account for 3.5% of all deaths worldwide. And the statistics shows that the liver disease is on the rise. 1 in 4 Canadians may be affected by liver disease, including everyone from newborn to older adults. In fact, many experts nowadays warn against taking your liver for granted, as it could be the Kickstarter for cardiac events later. And surely we'll know more on this connection today. Our expert speaker, Dr. Mamatha Bhat. Dr. Bhat, thank you for joining, and a very warm welcome to you. Friends, Dr. Bhat is a hepatologist and clinician scientist at UHN Ajmera Transplant Center, and assistant professor of medicine at University of Toronto. And she's also a scientist at Toronto General Hospital Research Institute. After doing medicine at McGill University, she completed a transplant hepatology fellowship at Mayo Clinic, Rochester, Minnesota, followed by Canadian Institute of Health Research Fellowship for Health Professionals, through which she completed a PhD in medical biophysics at University of Toronto. Dr. Bhatt's research work has led to improved long-term outcomes in the liver transplantation through a precision medicine approach. Her program is unique worldwide in using tools of artificial intelligence to personalize the care of liver transplant recipients based on improved biological understanding of the liver after transplant. She got the prestigious John Charles Polanyi Prize in Physiology Medicine for her research to ensure long-term health for the patient who undergo liver transplant. And today's topic is titled The Liver in Health, Disease, and Transplant. And we look forward to the very latest information available in medical science from Dr. Bhat on liver diseases, transplants, and of course, her view on the role, function, and health aspect of living donors. Those selfless individuals who by their voluntary action have the power to give. So, Dr. Bhat, we sincerely thank you for joining us on Saturday morning. I know how busy your schedule is, and thank you. We're looking forward to your great presentation, and over to you.
Hey, thank you so much, Mr. Tucker, for the kind invitation to present, for the opportunity to present at this webinar by the Canada India Foundation. So I'll just share my screen here. So as Mr. Tucker mentioned, the focus of this talk is on the liver in health, disease, and transplant. And this is the outline of my talk. So I'll start off by describing the functions of the liver, What is chronic liver disease? What are the different types of liver diseases? What is cirrhosis? And then the role of liver transplantation, as well as living donor liver transplantation. And finally, talking a bit about research in liver transplantation to improve outcomes after transplant. So the liver is this organ as depicted in this figure. So it sits in the right upper quadrant of your abdomen, right under the rib cage. It weighs in at just over 1 kilogram. It's a complex chemical factory that works 24 hours a day. And you can see that it's really primely positioned in relation to the stomach and the bowels. So whatever nutrients are ingested, digested, and absorbed by the gut, then travel through the blood to the liver to become metabolized. And so whatever bacteria, et cetera, that travel through the bloodstream as well, go through the liver. So this is really primely positioned and really to perform its critical functions. So the liver is divided into two main lobes. There's the right lobe and there's the left lobe, and it's subdivided into 8 segments. It consists of functional units called lobules. So as you can see depicted here, this is a lobule. And so this functional unit is actually critical to carrying out these specialized functions. And it consists of, as mentioned here, over 1,000 lobules. And these lobules then serve to carry out the functions of the liver. The lobules produce bile, which then drains into the bile ducts, and then these bile duct branches then drain into the common hepatic duct, which then transports bile to the level of the gallbladder for concentration. And then finally, the bile is then transported through the common bile duct to the level of the small bowel. And I'll get into why the lobules, as well as the position, the anatomy of the liver in relation to the organs, is quite critical in carrying out these functions. So the liver performs over 500 functions, and these multiple functions are essential to life. So as Mr. Tucker was mentioning, really, in general, we tend to take the liver for granted, but it's quietly performing various functions that are critical to one's life. There are 3 major categories of functions of the liver. So the liver acts as a filter. It is a major chemical factory. So it is the major chemical factory of the body. And it also detoxifies. And I'll get into these various categories of functions in the subsequent slides. So in terms of filtration, it processes nutrients that are absorbed from the digestive tract. So as I mentioned, you consume food, it's grinded up by the stomach. Those nutrients are then sent down to the level of the small bowel and absorbed from the digestive tract. So there's some enzymatic activity, et cetera, that will allow for further digestion. And then these nutrients are absorbed from the digestive tract and then sent through the bloodstream, through the portal vein into the liver. Additionally, the liver removes bacteria. So there's bacteria that will be traveling through the bloodstream normally, but then there can be some sinister bacteria as well. And these bacteria are detected by the liver, which is really a highly immune organ. So it is a very important component of our immune system, really. It also produces critical immune factors. So it produces proteins such as complement proteins that are critical to engulfing bacteria or detecting bacteria as well. So this is the filtration function of the liver. The liver is also the major chemical factory of the body. So it produces a wide variety of proteins. It produces bile, it produces plasma proteins, including albumin, which is critical. It's the major protein that allows for maintenance of the blood pressure. It also produces clotting factors, which is necessary for the blood to clot. Protein metabolism, carbohydrate metabolism, lipid metabolism, these are also major functions of the liver. There are various enzymes and proteins present in the liver in those functional lobules that allow for these different functions and enzymatic activity or processes that result in metabolism. And it also regulates the supply of essential vitamins and minerals, including iron, copper, and various other essential minerals. Hormonal regulation as well, so thyroid hormones, sex hormones, corticosteroid hormones, these hormone levels are actually also regulated by virtue of the liver, because the liver produces proteins that bind to these hormones and regulate their levels in the blood. So the final major category of functions is detoxification. So the liver detoxifies, it excretes bilirubin and removes waste products such as urea. It also is the major metabolizer of drugs. So say you take medications, those are going to be metabolized by the liver. Additionally, toxins such as alcohol are also metabolized by the liver. The liver produces up to 600 milliliters of bile per day, which is comprised of water, electrolytes, and organic compounds. Bile acids are essential for excreting toxic compounds, as well as solubilizing ingested fat and fat-soluble vitamins. Additionally, phospholipids, cholesterol, these are all components of the bile. So now I'll get into a question. This is just a general question to give you a sense as to what are the causes of liver disease. And so what causes liver damage? And here you have a list of potential causes. So hepatitis C, B, non-alcoholic fatty liver disease, C, alcohol, D, primary biliary cholangitis, E, Wilson's disease, F, all of the above. And so finally, the answer is all of the above. So in the general population, most people think of liver disease as being caused by viruses, alcohol, and fatty liver disease. But there is a whole slew of diagnoses, as you can see here, but actually there are many more than this. I'm just giving you general categories. So there's hereditary causes such as hemochromatosis, which is iron overload, Wilson disease, which is copper overload, alpha-1 antitrypsin deficiency, autoimmune liver diseases. So this is because the immune system is acting against the liver proteins, certain liver proteins. And this results in inflammation, resulting in autoimmune hepatitis or primary biliary cholangitis or primary sclerosing cholangitis, viral infections such as hepatitis B, C, and D. So these are also major causes of liver disease worldwide. Toxins such as alcohol are an important cause of chronic liver disease worldwide as well. Certain medications such as methotrexate, amiodarone. Additionally, fatty liver disease. So this is where there's significant accumulation of fat within the liver, and particularly individuals who have diabetes or obesity, so a body mass index greater than 30, a family history, so there may be some genetic propensity to this. So these are risk factors for fatty liver disease, and this is really becoming the dominant liver disease in the Western Hemisphere and a growing reason for liver disease in the South Asian population. So it's an important reason for liver disease in the South Asian population. In addition to hepatitis C and alcoholic liver disease. Vascular causes such as Budd-Chiari syndrome and acute liver failure due to Tylenol overdose, herbal medications, or antibiotics. So these are the major categories and causes of liver disease, but certainly, as I mentioned, there are many other causes of liver disease that are not mentioned here, but this just gives you a general idea as to what are causes of liver damage. And so the reality is that chronic liver disease is often difficult to diagnose, as the symptoms can be vague and can be confused with other health problems. So many people may have no symptoms, even if they've developed significant damage to their liver. The risk factors vary across the over 100 different forms of liver disease. Nonetheless, many liver diseases can be prevented, managed, and even in some cases cured. So for example, for hepatitis C, now we have antiviral medications that are quite potent and allow for cure in the vast majority of cases, 99% of cases. Early identification of liver disease is critical in order to prevent the development of cirrhosis. And additionally, lifestyle factors are actually quite critical. So a healthy diet, maintaining a healthy weight through this healthy diet and exercise, minimizing alcohol consumption, avoiding high-risk practices for acquisition of viral hepatitis, such as viral hepatitis B or C. How is liver disease diagnosed? So liver tests, particularly alanine aminotransferase, aspartate aminotransferase. So these are liver enzymes that are released into the bloodstream when liver cells die. So if there's ongoing liver damage, so inflammation of the liver and damage to liver cells, this results in the release of these enzymes, namely ALT and AST. Additionally, alkaline phosphatase is released when there's bile duct inflammation. Liver function is represented by bilirubin, total bilirubin, INR, which is a representation of clotting function, and albumin, as I mentioned earlier. So albumin is the major protein that is present in the blood and allows for maintenance of blood pressure. So when the liver doesn't function normally, so say patients with cirrhosis, they will have lower blood pressure, principally because of a low albumin level in their bloodstream. Tests for, say, investigating liver enzyme elevation include testing for hepatitis B and C presence. So we test for serology, so antibodies against these viruses, as well as the actual virus presence. We also will check for antibodies against certain autoimmune liver diseases, so immunologic tests for autoimmune liver disease. We also will test for iron or copper overload. Additionally, the physician will ask a thorough history regarding alcohol consumption. Additionally, diabetes, obesity are important risk factors for fatty liver disease and worsening of underlying liver disease. And family history is also an important, say, historical point to obtain from the patient who has elevated liver enzymes. In terms of imaging tests, so we perform an ultrasound, additionally transient elastography, which is a test to determine the degree of scarring in the liver, may be performed particularly at liver clinics. So this is basically a type of test that allows for waves to be sent into the liver, and then when those waves are returned back, you get a sense of, say, the stiffness of the liver. So this gives you a sense of how much scar tissue there is in the liver. And so liver biopsy is the gold standard diagnostic procedure to then determine what is causing the liver disease and what is the degree of scarring in the liver. So what is cirrhosis of the liver? So on the left, you see here a normal, healthy liver. So it has normal tissue. And here on the right side, you have a cirrhotic liver. So cirrhosis, meaning full-fledged scarring of the liver. And as I mentioned earlier, there are various types of chronic liver disease. So here you have a normal liver represented. And what happens is the liver sees these different types of liver disease as insults. So what happens is, say, with viral hepatitis C or hepatitis B or alcohol or fat or the whole list of liver diseases, it sees these as really insults. And so the immune system then reacts to those insults, and that results in the development of inflammation or ongoing hepatitis. Hepatitis basically refers to ongoing inflammation of the liver in response to an insult. And when there's ongoing inflammation of the liver in response to this insult, then there is triggering or activation of certain cells within the liver that cause scarring. So it's a healing response But paradoxically, this healing response ultimately over many, many years can result in cirrhosis. And so what happens is over many years, say 20 to 25 years, people can develop cirrhosis if they have chronic liver disease. And so these are the different stages of scarring of the liver. So you go from stage 0 to stage 4. So stage 0 is the healthy liver. When there's persistent inflammation resulting in collagen deposition over time, this results in progressive scarring. So stage 1 is the beginning of liver damage. Stage 2 is moderate liver damage. Stage 3 is significant liver damage. And stage 4 represents severe liver damage. And so the scar tissue over time will also kill healthy liver cells, causing even more scar tissue to develop. And this will affect blood flow through the liver. So this is called portal hypertension. I'll show you some figures to illustrate this further in subsequent slides. But basically, the blood flow through the liver is compromised by this scarred down liver. And so fibrosis in mild to moderate at a mild to moderate degree often does not cause symptoms. So as I mentioned, it takes many years to develop cirrhosis. And part of the reason for that is that the liver has this regenerative capacity as well. So it not only has this healing response, which results in scarring, but it also has a separate healing response wherein it's able to regenerate in response to ongoing insults. And it really is the one solid organ that is capable of that. So the skin and the gut are able to rapidly regenerate. So basically there's this dynamics in terms of the turnover of the skin and the gut. And the same can be said for the liver. This is not true for, say, the kidneys, the heart, and the lungs. So those organs do not have a regenerative capacity. And really, the liver is this one organ that has this dramatic regenerative capacity. So this is really what protects the liver from developing cirrhosis in a shorter period of time. So this really occurs over many years. So in compensated cirrhosis, so compensated cirrhosis basically means that they don't have the complications of cirrhosis, which I'll get into in subsequent slides. So with liver cirrhosis, individuals may or may not feel sick. They may feel tired. They may have poor appetite, nausea. Additionally, they have a higher risk of primary liver cancer. So when liver cells regenerate, they have this propensity to accumulate mutations or propensity to develop cancer. And so this is why most cases of liver cancer arise in the setting of cirrhosis. And so this is why it's important to do screening ultrasounds every 6 months in individuals who are at risk of developing liver cancer, namely patients with cirrhosis. Treatment of liver disease and cirrhosis basically requires treatment of the underlying cause. So for hepatitis C, for example, as I mentioned, we have potent antiviral medications that will allow for treatment of the underlying cause. Then you monitor and treat the symptoms of liver disease. And it's important to keep in mind that once cirrhosis is established, it's very difficult to reverse that cirrhosis. So here are some, to conclude this particular part of the talk, so I'll give you a sense of the Canadian statistics for chronic liver disease and cirrhosis. So chronic liver disease affects more than 3 million Canadians. It's projected to rise in the coming years with increasing non-alcoholic fatty liver disease alongside diabetes and obesity. Additionally, the death rate for chronic liver disease in Canada reached over 10 deaths per 100,000 in 2021, and Canada had approximately 5,000 deaths due to liver disease in 2021. So now I'll get into the role for liver transplantation in relation to end-stage liver disease and liver cancer. So what happens when the liver fails? So this is when cirrhosis gets worse and there are certain symptoms and manifestations, complications of cirrhosis that increase the risk of death. Additionally, as I mentioned, individuals with cirrhosis can develop liver cancer, which also can account for mortality or death in the setting of liver disease. So this is a figure basically representing cirrhosis again, so decompensated cirrhosis. And what happens in decompensated cirrhosis, so as the cirrhosis gets worse and worse, there's a lack of functioning liver cells. And so this metabolic factory function of the liver is unfortunately compromised. And so you have low protein production, namely low albumin and the various other types of proteins that the liver produces are compromised. There's a higher bleeding risk, but also higher clotting risk. So there's a bit of an interesting balance issue in terms of clotting and lack of clotting. Additionally, detoxification, so that particular function is also compromised. So patients can develop encephalopathy, which is basically accumulation of ammonia, which is a protein byproduct. And so that ammonia will travel to the level of the brain and cause false signals, so sedating signals that decrease the level of consciousness of an individual and cause confusion. And jaundice is an important manifestation as well of decompensated cirrhosis or end-stage liver disease. Now, in terms of the function of the liver, so this is represented by the sodium MELD score. So the sodium MELD score really is a reflection of how severe the liver disease is. And so I'll give you an idea of that in the next slide. So the MELD sodium score calculator is predicated on the creatinine, the bilirubin, the INR, and the sodium. And so this is a LON-based formula. So the creatinine value is entered, bilirubin, INR. So this is, as I mentioned, it's a representation of clotting function. So these various parameters are inputted, and finally you get a score. So that score is a result between 6 and 40, and it represents the degree of liver disease or liver dysfunction that an individual has. And so a score of 11, just to give you an example, a score of 11 gives a 3-month mortality or 3-month risk of death of 6%. A score of 33 gives a 3-month risk of death of 53%. And so we consider liver transplantation is indicated when the MELD sodium score is 15 or greater. And then it's also considered on a case-by-case basis if the score is between 10 and 15. So as I mentioned, there are two main components of decompensated cirrhosis. There's a lack of functioning liver cells, and there's also portal hypertension. So again, portal hypertension is because there is this compression of the portal vein flow. So the cirrhotic liver, the liver with cirrhosis compresses on the portal vein. And so the flow to the liver is compromised. And this pressure wants to redistribute itself to the spleen and to the stomach and the esophagus. And so what happens there, when it redistributes its pressure, it develops what we call collaterals. So there is this now onset of dilated veins within the digestive tube from the mouth to the stomach. So these are called esophageal varices, and these are at risk of bleeding in individuals with worsening cirrhosis. Additionally, the spleen will become enlarged. And additionally, another important manifestation is the accumulation of ascites or fluid within the abdomen. And this is because individuals with cirrhosis have low blood pressure. And again, I mentioned the albumin being low. So when they have low blood pressure, the kidneys see less blood flow, and the kidneys want to retain salt and water. And so when there's salt and water retention, there's this accumulation of fluid within the abdomen, accumulation of fluid within the legs, and there's a higher risk of developing infection, including infection of that fluid within the abdomen. The peritonitis, as mentioned here, is basically infection of that fluid. There's additionally the risk of developing kidney issues with the accumulation of ascites. And then I also mentioned hepatic encephalopathy, or the confusion associated with ammonia accumulation. And so what are the, say, associated survival rates with compensated and decompensated cirrhosis? So compensated cirrhosis is associated with a very good survival, 1 year survival of 99%. However, once decompensation occurs, so this is manifested by ascites, bleeding varices, or hepatic encephalopathy, then unfortunately, that's when the survival is compromised. So 74 to 85% 1 year survival with ascites, 46% 5 year survival associated, and then bleeding varices, 85% 1 year survival, 75% 5 year survival, and with hepatic encephalopathy, 53% 1 year survival. So this is really when we start talking about transplantation. And so liver transplantation is indicated for end-stage liver disease or decompensated cirrhosis, liver cancer, or acute liver failure as the major indications for liver transplantation. There are other indications that I won't get into as part of this talk, but these are the major indications to give you an idea. And the important thing to know is that there is no machine, there is no dialysis machine that can replace the liver's complex functions. So there are over 500 functions of this organ, and there's no machine that can replace those critical functions. And so in the case of kidney, lung, or heart, you do have machines that can replace the functions of those organs. Unfortunately for the liver, there is no machine that can replace the liver's complex functions. And so liver transplantation really is the one curative therapy for patients with end-stage liver disease. And so here you have a figure of the transplanted liver. So this is the donor liver, which has been implanted into the recipient. And you can see that connections have been made between the donor bile duct and the recipient bile duct, the donor portal vein and the recipient portal vein, and then the donor hepatic artery and the recipient hepatic artery. So these are the three main, say, vessels that need to be connected between the donor and the recipient. And additionally, on the other side, so in terms of drainage of the metabolized products, metabolized byproducts, and so on, so these are all drained by the hepatic vein branches, which then drain into the inferior vena cava, which is the major vessel that then travels to the right heart. And so that basically is the anatomy of a liver transplant. A liver transplant procedure is around 6 to 8 hours in length. It can vary between, say, 4 to 6 hours rather in length. And there are certain associated risks, but obviously there are clearly benefits in individuals, many individuals with decompensated liver disease. There are certain contraindications. I won't get into this as part of this talk, but there are certain contraindications as well. So the rest of the body needs to be able to tolerate the stress of a liver transplant. So say the heart, the lungs, etc., will need to be in decent shape, as well as being able to perform the activities of daily living independently. So these are various other aspects considered when we evaluate a patient for transplant. So this is to give you a historical perspective on liver transplantation. The first human liver transplant was performed in 1963. First successful transplant was in 1967. Canada's first liver transplant occurred in Montreal in 1970. Until then, the 1 year survival was 25%. Finally, in 1983, the National Institutes of Health in the US established liver transplantation as the definitive treatment for end-stage liver disease, so it was no longer experimental. Over time, there were improvements in and refinements in anti-rejection medications, which are actually essential to protect the organ from rejection, because this organ comes from a different person. It is seen as foreign by the immune system. And so anti-rejection medications are critical to protect the liver from getting rejected. And finally, in 2000 as well, living donor liver transplantation developed as an important way to address liver transplantation. And that demand for organs. So now I'll give you a sense of the indications for liver transplantation at the University Health Network over the last few years. So just a general sense, so hepatitis C has been the dominant indication and now is becoming a lesser indication with the curability of hepatitis C. Alcoholic liver disease is an important indication, and non-alcoholic fatty liver disease is increasingly becoming a dominant indication. It's become the second leading indication for transplant in the US and is forecasted to become the dominant indication. Liver cancer is an important indication, so represents 35% of the liver transplant activity. There is certainly a need for further donors. So prioritization for liver transplantation is based on the MELD sodium score. And as you can see in this figure, there are a number of patients who are added to the wait list. However, the liver transplantation performed cannot meet the increasing demand. So organ supply is unable to meet the increasing demand. In Canada, in 2020, 540 liver transplants were performed. The average MELD sodium score at which patients are transplanted is 28 to 29 in Ontario, just as an example. So it means that individuals have to become very sick in order to attract a deceased donor organ offer. And so this means that 25 to 30% of our patients unfortunately pass away or drop off the waiting list from the transplant waiting list. And so this gives you an idea of the different types of organ donation. So there is brain dead organ donors, cardiac death organ donors. So these are donors in whom the liver is functioning normally. And so these organs are retrieved from individuals who have indicated their willingness altruistically to donate their organs at the time of death. Additionally, their families have indicated their interest on behalf of the donors to provide this as a means to save the life of someone on the waiting list. Additionally, living donation, so living donor liver transplantation is another way in which liver transplantation is feasible. And in this case, the donor gives up to 70% of their liver to the recipient and keeps 30 to 40% of the liver. And so this is living donor liver transplantation. So as I mentioned, up to 70% of the donor's liver is resected and implanted into the recipient. This is only feasible because the liver has this miraculous ability to regenerate itself. And so it regenerates over a 3-month period of time in both the donor and the recipient. So 2 to 3 months. Over that period of time, the liver is able to then achieve a close to normal volume. And this is a life-saving transplant with minimal waiting time, decreased risk of dropout or death on the waiting list. There's a faster return to good health and good quality of life, and better long-term outcomes, better quality organ. So just to give you a sense, at the University of Health Network, we perform over 200 liver transplants. And of those, 50 to 70 are living donor liver transplants. So this really allows for better long-term outcomes, as was shown from a recent publication from our program. Additionally to the donor, in terms of the donor, so living donors are aged 16 to 60 years. They're otherwise in excellent physical and emotional health, have normal liver function. This is a voluntary choice, and donors gain a deep sense of satisfaction from having saved a life. And these are really altruistic individuals who step forward to provide a portion of their liver to a recipient in need. Now I'll get into long-term outcomes after transplant. So 1-year survival rates have dramatically improved in the last 3 decades, from 65% to 95% 1-year survival. And this is despite, say, the growing burden of, say, diabetes and other illnesses that are heavier on in terms of the candidates who are stepping forward for evaluation. Additionally, in terms of survival after liver transplantation, so 80% survive up to 5 years and beyond, and 70% up to 10 years and beyond. So really, there have been dramatic improvements in terms of 1-year survival rates. However, in terms of long-term survival beyond a year, this has remained a bit stagnant actually over the last 30 years. And so there's some work to be done in that regard. So recipients, as I mentioned, must take anti-rejection medications for the most part lifelong to protect the liver from rejection. But by virtue of that, they also have a higher risk of cancer, heart disease, diabetes, and infection. And so it's important to consider how we balance the benefits of anti-rejection medication with the risk of complications in order to ensure that their care is optimized. And in this regard, there is limited evidence in terms of how we can maximize the survival of a liver transplant recipient. Just to give you an idea, the median survival of a liver transplant recipient overall is, considering all individuals, so from the age of 18 onwards, is significantly less than the Canadian life expectancy. So how do we really balance those benefits versus risks of anti-rejection medication? And so in my program, what we've used is some artificial intelligence to allow for personalization of care. And this is a paper we published last year. We used deep machine learning algorithms to predict patient outcomes after liver transplantation. And this model incorporates changing patient data over time. And really, this historical data then informs our prediction of death and a death related to cardiac disease, heart disease, cancer, infection, and graft issues. And we're able to use this information in the future. We will be able to use this information to guide their care. And so what we're developing right now is basically a dashboard to allow for clinicians to get an updated 1-year and 5-year probability of each outcome at every appointment, and then obtain a list of ranked features or predictors of these complications for each of the outcomes, thereby allowing us to personalize the care and management of the modifiable risk factors in an individual liver transplant recipient. And so now I'll conclude my talk by summarizing all of the points covered. So the liver performs multiple functions essential to life. I hope I've convinced you of that. It's uniquely capable of rapid regeneration. There are several different causes of chronic liver disease. Fatty liver disease is currently the most common chronic liver disease in Canada. Cirrhosis develops over decades. Liver cancer develops in the setting of cirrhosis most often. It's important to realize that there is no dialysis machine currently that exists to replace the complex functions of the liver. And finally, liver transplantation is a life-saving therapy for end-stage liver disease, and living donor liver transplantation is an avenue to liver transplantation, especially considering that mismatch between organ supply and demand. And so I'll also give you some websites of interest that I think are very helpful in terms of information. So regarding transplantation, so the UHN Foundation website, the Canadian Liver Foundation website, as well as the Gift of Life website. And I'd like to also acknowledge my colleague, Dr. Tsien, who provided some of the slides I used in this presentation, as well as the UHN Living Donor Program and the Canadian Liver Foundation. Thanks very much for your attention, and happy to take any questions at this time.
Thank you so very much for such an enlightening presentation, Dr. Bhat. I think it was so fascinating to learn that how human body, various organs within works, and we take so many things for granted, but all living organs and processing so many activities, it was very enlightening and very learning. Thank you for sharing in such a simple words, so a layman can understand. And I think the purpose that one, parting the knowledge, and second, through that knowledge, that how we can help ourselves. Of course, one is the disease management, another thing is the prevention. Mm-hmm. And I think it's very helpful for all our audience. We have some questions. Let me go on the question box. So my first question is that can liver transplant be successfully carried out with the stage 2 cancer?
Yeah, so liver cancer is an indication, an important indication for liver transplantation, but it should be confined to the liver and with a certain tumor burden. So the reason we consider, so this is a very unique paradigm in transplantation wherein transplant of a solid organ is performed for cancer as an indication. So this is not done in, say, lung, heart, or kidney. The reason for that is because the underlying liver is itself damaged. So what happens is, many people with liver cancer will also have portal hypertension. So even if they have a single cancer, if you resected a portion of that liver, then the liver would fail, resulting in death. So that's one scenario. Another scenario is there are multiple areas of liver cancer within the liver. So that's another, say, scenario wherein liver transplantation will be considered. So those are the two main, say, sort of scenarios. And really, the liver cancer has to be restricted to the liver within a certain, what we call total tumor volume. So 145 centimeter cubed is the total tumor volume. They must have no more than a certain level of alpha fetoprotein. So this is a type of protein that is produced by the cancer. So if an individual has liver cancer within the confines of the liver with no, what we call, spread outside of the liver, then they can be considered for liver transplantation. So there is a certain risk of recurrence of the liver cancer also. So after transplant, say someone is transplanted for liver cancer, there is a risk of recurrence of 15 to 20%. And it tends to be, if that recurs, there is a bit more aggressive behavior. There is more aggressive behavior because they're taking anti-rejection medication. So the anti-rejection medication, what that does is it suppresses the cancer sensing mechanism of the body. So, your immune system actually is able to recognize bacteria as foreign. It recognizes cancer cells as foreign. So the immune system is actually very important in that regard. So it's important to realize that liver cancer is an indication for transplant, but within certain criteria, because it really has to be confined to the liver.
Okay. Oh, thank you. And my next question is that which medications cause liver disease, and what are those medications used for?
Okay. So medications that can cause, say, acute liver failure, for example, Tylenol or acetaminophen. So this is the major reason for acute liver failure or fulminant liver failure. And this occurs in the setting of overdose. So say someone has intentionally or unintentionally taken a large amount of Tylenol, then that can result in what's called acute liver failure. Actually, in some countries, they restrict the over-the-counter supply of Tylenol because of that problem. So in Britain, for example, they restrict over-the-counter availability of paracetamol or acetaminophen because of that risk. So, many of the, say, the acute liver failure indication here in the Western Hemisphere in North America is predominantly Tylenol overdose. But there is also, say, relation to antibiotics, specific antibiotics, sometimes for some unknown reason in genetically susceptible individuals can result in fulminant liver failure. But this is quite rare. So, I wouldn't be concerned about that specifically. Additionally, certain herbal medications like green tea consumed in excess can be associated with acute liver failure. Now, in terms of medications people take in a chronic way, so methotrexate, so this is a medication that is used for rheumatoid arthritis. So if it's taken over a very long period of time and there's a certain dose that is consumed over that period, that can result in damage to the liver. Amiodarone, which is a an antiarrhythmic medication for heart disease. So atrial fibrillation or heart arrhythmia, heart rhythm problem, also can be associated with chronic liver disease. But really, this is something that people should discuss with their doctors. If they're taking a medication, these things will be considered. Like, say, if someone does have liver disease, then certain medications will be avoided. So additionally, say, sedative medications will be avoided because individuals with cirrhosis, for example, have a higher risk of encephalopathy or confusion, and they have a higher risk of drowsiness, and so on. So certain medications are avoided in that setting. But in terms of chronic liver disease and acute liver failure, these are the main, say, medications and insults to be aware of.
Oh, thank you. My next question is there any age limit by when liver stops growing? And like, as we age and as we grow, what age limit, like liver grows to the fullest capacity? As you mentioned, it grows, kind of organically, but is there any limitation to it? Like after a certain age, you don't see liver growing?
So the liver doesn't, say, grow, but there is some ongoing what's called liver cell turnover over time. And so the interesting thing we see is that, say, a young patient presents with liver disease, say they develop liver cirrhosis, for example, alcoholic liver disease. So young individuals with alcoholic liver disease that is quite advanced. So they have the fluid accumulation, they have the confusion, etc. They have very bad disease. The amazing thing about younger individuals is that they can recover that liver function to a significant degree over time. So if you remove that insult, if you remove the alcohol, which was the instigator of that end-stage liver disease, the liver can regenerate and heal itself to a remarkable degree. And so that's important to consider. But this is mainly in younger individuals who have no other issues, like they don't have diabetes, they don't have any other sort of issues that will compromise their liver's ability to regenerate. But say in older individuals, so say when I see a patient with end-stage liver disease in their 60s, then I know, well, this person's capacity to regenerate and heal is limited. So then I know, okay, well, here we have to be more careful and, consider liver transplantation earlier because these individuals have a limited capacity for regeneration. In younger individuals, I mean, this is for most that I'm talking about, there is this regenerative capacity. So that's what's very unique about the liver. The same can't be said for the kidneys or the heart, the lungs as well. So it's really unique to the liver.
Thank you.
You're right about the age. Certainly, older age is associated with less capacity for regeneration. The other interesting thing about the liver is that when it starts regenerating, so like say in the living donor or in the recipient, the remarkable thing is that it starts regenerating, but then it knows when to stop growing. So it stops growing when it's achieved the liver volume that is necessary for survival in the long term. So there is a mechanism to tell the liver, okay, this is where you stop growing.
Excellent. We talked about fatty liver. Any preventative, a person who's healthy, what he should be mindful of, so he does not, develop any kind of issue. As you mentioned, no early warning signal he can get. So any preventative things, don'ts we should be aware of or taking care of?
Yeah, so the interesting thing is that, liver enzymes are not regularly checked as part of the standard blood tests that you do with your family doctor. Right. So, and this is probably something that should be done, especially in individuals who have diabetes. So there may be some ongoing inflammation due to fatty liver disease that can be detected earlier in order to treat. But the important thing to say here is that, say, a healthy, well-balanced diet, low in fat, low in sugar, so decreasing the sweets, decreasing the fried foods, maintaining a healthy body mass index. So for a South Asian, that's between 18 to 23, really. I mean, for Caucasians, it's up to 25. So that is ideal to prevent fatty liver disease, for example. So healthy diet, exercise. Additionally, if individuals have diabetes, having good control of that diabetes to prevent damage to the liver in the longer term. Alcohol consumption needs to be minimized as well. So there's a certain, say, standard recommendation in terms of alcohol consumption. So you can look at that, say there are Canadian guidelines for standard alcohol consumption. So those are important to follow as well. So 1 to 2 standard drinks, a daily maximum for a woman, up to 10 per week. Overall for men and women. So I would say that those are important to follow, because the problem is that, moderation, like if moderation is exceeded, so if you go beyond what's recommended, then there's always the potential of stressing the liver and causing inflammation of the liver over time and damage to the liver over time. Okay. Otherwise, I think the other thing that's important, I think, for the South Asian community is, say, screening for hepatitis B and hepatitis C. So hepatitis B will be tested, but hepatitis C, especially in the baby boomer population, has been recommended by the Canadian Liver Foundation for the last over 5 years now. So testing for hepatitis C is also important. You should discuss this with your family doctor. And accordingly treat, because hepatitis C is now curable.
Right.
Yeah.
No, excellent. And Dr. Bhat, you mentioned about for the living donor that from the 16 to 60 year of age.
Yes.
Is there any exception, a person who's very healthy, no issue whatsoever, even over the age of 60, can he be the donor? Number one. And number two, my question is that any long-term risk for the living donors?
Yeah, okay. So with respect to your first question, so in our program, we consider individuals who are perfectly healthy with no other conditions between the age of 16 and 60. If they're beyond that age, we don't consider them, because the rate of regeneration or that regeneration capacity is going to be compromised. However, I should also say that in Eastern Asian countries, like South Korea is a very important, so they do a lot of living donor liver transplantation over there. And there they do consider older donors. But at least in Canada, North America, we don't consider donors above the age of 60. So they need to be perfectly well. In terms of long-term risks, so to the donor, right? So that's the question. So,
yes.
With respect to risks to the donor, so it is important to know, and we tell this to all individuals who step forward, that there has been in the literature a reported 0.2 to 0.5% chance of mortality or death after giving a portion of their liver, but that's really the worldwide experience. And so in higher volume programs such as UHN, for example, where we do a number of living donor liver transplants, there's lots of expertise and skill. So in terms of managing and performing the surgery, as well as managing individuals afterwards, there have been, fortunately, no such adverse events. Now, there are certain complications that can arise after giving a portion of the liver, such as bleeding, infection, a bile leak, as well as a higher risk of clotting. But these are, potential risks, but nonetheless, these are addressable risks over the period of time as they recover. Usually the living donor will spend about 5 to 7 days maximum in hospital, and they're usually able to get back to regular activities, very easily by a month, and even go back to work by 3 months or even earlier in most instances. So these are relatively well, as I mentioned, they're very well individuals who are stepping forward.
Excellent. And since how long UHN been performing this liver transplant?
So liver transplantation at UHN has been since the 80s, but living donor liver transplantation since 2002.
And how many on an average every year is being?
So so in 2021 we performed 216 liver transplants in total on the adult side, and over 20 on the pediatric side, on the kids side, so at Sick Kids Hospital. And living donor liver transplants, of those were between 50 and 70. So a large number of living donor liver transplants. And really that's, crucial in terms of decreasing, as I mentioned, the death on the waiting list.
Right.
So it really gives many more people a chance to get to transplantation and have that second chance at life.
Excellent. And my final question, I know we are running out of time, that is there any kind of vitamins that can be taken for the liver health function? I guess as a preventative, yeah.
Not really. I mean, so in terms of fatty liver disease, there was previously an important study published on vitamin E in terms of treating fatty liver disease. So certainly in individuals who have fatty liver disease, vitamin E traditionally has been considered as an antioxidant treatment for fatty liver disease, but it's not, say, officially endorsed or approved for that indication. Now we have, increasing evidence for various medications to treat fatty liver disease. And you'll see in the coming years that we have more and more evidence to treat patients with that condition beyond diet and exercise. In terms of, silymarin is one medication that has been used traditionally by patients with hepatitis C to decrease scarring of the liver. But that, I don't normally advise my patients to take that. I would say overall, it's just best to, focus on preventive measures, including this healthy diet, exercise, avoiding high-risk behaviors, including the alcohol consumption in moderation. And those really are the critical things to help protect the liver in the longer term.
Excellent. Well, that's, I think this is a conversation we can keep continuing for hours and hours, but we are constrained with the time. And on behalf of Canada India Foundation and all the participants who joined virtually, as well as on our Zoom platform, we want to sincerely thank you for your time and sharing your knowledge, wisdom, and experience with us. I think it was very, very helpful for all of us. And we sincerely thank you and wishing you a great success in all your endeavors. Please do keep sharing, your knowledge and wisdom with the community. That's very, very helpful. I know how busy your schedule is, and sharing your Saturday morning with us, it means to us and a lot, and we sincerely thank you. And I want to thank all our participants for joining this morning. Please do write any feedback you might have to us, and also any future event you might be interested in. Canada India Foundation has been working on this sector, healthcare, for last couple of years. And I would say since the day we formed almost a decade and a half ago, and it's a very key priority area that how we can spread good health and wellness. And please do write to us any other topics you might be interested in. So we'll keep that into our calendar. And I also want to take this opportunity to thank our media partners, Y Channel, who's been supporting us from day one in broadcasting our various events. So thank you all. Wishing you a very, very happy weekend ahead. Today, Saturday, Sunday, enjoy your day. And thank you for joining once again.
Thank you very much for the
Namaskar.
opportunity. Thank you.